Today, we'll be discussing how healthcare and tech can face the ballooning mental health crisis with scalable behavioral health resources and specialists. Specifically, what role can AI and machine learning play in addressing this tension? Joining us today is Roger Dowdy, Providence Health's Vice President for Mental Health Strategy, and Israel Niesen, who is the CEO of Factored. Factored is a Palo Alto-based company that helps tech companies select, train, and build world-class data science, machine learning, and AI engineering teams much faster and much more cost-effectively. No one could have anticipated the pandemic that unfolded, but beyond the direct loss of life caused by COVID-19, today we're going to be talking about what might be the most pronounced and longest-lasting health-related side effect, if you will, of this pandemic, which is the ever-inflating mental health crisis. On one hand, it's not a surprise, but on the other, it's pretty shocking. The relatively limited data thus far suggests such an overwhelming problem facing not only people, but also our healthcare systems. Research from the CDC details significant increases in anxiety, depression, suicidal ideation, substance use, and other trauma and stress-related disorders affecting many subgroups, but particularly some of the most vulnerable and under-resourced. According to the CDC, young people, parents of young children, frontline workers, racial minorities, and unpaid adult caregivers have been disproportionately impacted from a mental health standpoint. From pre-pandemic, if you will, to mid-pandemic, which more specifically, this data point is from June 2020. So who knows how much worse it might look today, but the prevalence of anxiety disorders reported by adults in the US over that time increased by 3x, and reported suicidal ideation doubled. So Roger, can we hear a little bit about your work leading Providence's mental health strategy and your perspective on how we even start to make sense of the scope of this problem?
Yeah, thank you, Kelly, for that introduction and that background. You're absolutely right. The demand for mental health and substance use care really far exceeds the capacity that we have nationally to address those needs. And prior to COVID, at any given snapshot in time, any given day, about 20% of the adult U.S. population was experiencing some kind of mental health or substance use related concern. A recent study indicated that it's actually doubled. It's about 40% now from when we look at from now to baseline of last year. And about 1 in 10 adults have thought of suicide in the last 30 days. And that actually increases to 25% of young adults have thought of suicide in the last 30 days. And as you point out, this is not evenly distributed among the population. Some of our most vulnerable and communities of color are hit hardest. The other thing that's really startling and scary is that even pre-COVID, 60% of those folks individuals who had mental health needs went without care, were not able to access care, and 90% of people with substance abuse treatment needs were not able to get the care they needed. So this has become even worse now that the demand for services continues to go up.
Totally. Yeah, I mean, I can relate to that myself even. I mean, I've had the experience in pre-pandemic times of needing mental health support. And, I'm extremely tech savvy. I have incredible medical benefits through my employer. And even with all that privilege, I still found the process of connecting with a provider to be challenging at best and defeating at worst. I mean, finding that long list of providers and network, going through the list, contacting them all, putting yourself out there each time, and oftentimes not hearing back at all, or I'd hear back and find out, oh, they're not taking new patients, which was inconsistent with what, my insurance portal suggested. And just that feeling of putting yourself out there with every phone message or email to dead end in a system that's such in high demand and undersupplied. And my experience, and I assume many folks listening to this who have been through it can relate to it. It compounds a sense of isolation and helplessness when we're not able to meet people at that moment where they seek out help. And as you just said, Roger, as this is disproportionately affecting both younger people and people with fewer kind of resources and less privilege broadly, I can only imagine that experience compounding pretty significantly. And I think that's why I've been so excited for this conversation, because it leads us in this direction with the data suggesting, we're going to continue having increased demand. It's likely going to continue being folks with fewer resources, less likely to be insured, less likely to have flexibility in their daily schedule. And for some, it may be their first time ever trying to get mental or behavioral health support. So the need for innovation is urgent. And Israel, I think that's why Roger and I are so happy to have you here. I think the three of us and the two of you in particular are really going to open up some pretty interesting ideas. And I'm wondering, just to kind of prepare us and give us a bit of a primer, Israel, if you're willing just to give us a little bit of an overview on machine learning and AI for those of us who might be less familiar with it, and how some of the work you're doing at Factored could play a role in this problem that Roger just outlined, or similar problems with high demand and scarce resources.
Absolutely, Kelly and Roger. Thank you for welcoming me. So yeah, look, the way you might think about AI and machine learning in a very sort of basic description is the ability to teach computers based on data, to teach computers to sort of think cognitively and learn about problems, right? And learn in a similar fashion as humans might, right? For AI specifically, having you sort of describe this problem, AI for mental health specifically, I think we need to be really careful in thinking about the role of AI not as a replacement for licensed health professionals, but rather as a way to augment their capacity, right? Roger mentioned that demand exceeds capacity. And what AI is actually absolutely really good for is the efficient allocation of a valuable sort of resource, such as a health a therapist or a healthcare worker. And so I think we need to think about things like using AI to provide, you mentioned younger people are most affected by these issues as of recent. They all have mobile devices, they have digital devices, they know how to use them. So how can we use AI to provide convenient mental health assessments, right? Measure the depression, measure the anxiety, but also measure the urgency with which they need to be treated by actual humans, right? Based on that assessment, you can create better, more efficient recommendation systems that match them to the right providers instead of having to land on a website and have to sort of pick from hundreds or thousands of providers. You can actually find the best fit for them right then and there. And then use these mobile devices to track their progress, to stay in touch, and to stay in touch with them more naturally via devices that they know how to use, right? More conveniently, more frequently. I think these are the kinds of things where I think AI can help address this issue. Again, not replacing the certified providers, but actually augmenting their efforts, if that makes sense.
Totally. Yeah, I'm curious, Roger, to hear your thoughts on that as you listen to what Israel just shared and thinking about the landscape of challenges in front of you and your focus at Providence Health. Does that resonate? Like, how are you starting to think about bridging that gap?
Yeah, absolutely. We think a lot about the problem, and one of the concerns is as we think about this supply demand mismatch, and I don't want to. I use those terms, but don't want to minimize in any way that within that demand for services are individuals in need. But it's a way to frame the problem and think about it. And Kelly, you mentioned earlier some of the challenges of finding a clinician to see. And we know that the vast majority of people in the United States are seen in the private practice community. So psychiatrists, therapists who have a private practice on their own, and the challenge is that more and more of those folks, because as demand increases, are opting out of the insurance market altogether. And this isn't a criticism of my colleagues in private practice; it's just sheer market forces. But of course, that makes it even more challenging for those individuals who need to rely upon their healthcare benefits to be able to access care. And aren't able to pay out of pocket. In fact, there was recently a study a few months back by Milliman that said that folks have to seek care out of network from their insurance provider 6 times more frequently for mental health and addiction care than for other types of medical care. So it really speaks to this lack of parity that we have in our country with mental health and substance use care versus other medical concerns.
Yeah, absolutely. I mean, one thing that is really, I think, an interesting nuance of that adds to the complexity of mental health and behavioral health crises specifically is that, unlike kind of some of the other conditions you reference, like diabetes, where there might be a relatively kind of straightforward course of care or a pretty kind of standard range of and kind of steps and progression in managing an illness like that, it feels to me at least like there's a little bit more ambiguity when it comes to mental health conditions, right? I think which sort of practitioner you need to connect with, which sort of resources, is it a CBT approach, is it medication, is it a combination of all of those and many others I haven't mentioned? So just curious if you've run into that challenge and how you think that changes the complexity of this problem.
I would say it's really changing how we think about behavioral health care and treating it. We've had a traditional model, to be frank, because a bearded guy in Vienna 100 years ago said this is the way it should be. And if we think about any other industry, it has changed pretty significantly since then. And we as behavioral health services need to evolve as well. And part of that is changing the narrative as also. We frequently encounter folks who really want to see a psychiatrist, but what they're wanting is therapy. And that's not the best skill task alignment necessarily. Certainly there are psychiatrists that engage in therapy, but we're modeled in terms of media, what we see on television, that we always have to see a psychiatrist when that's not necessarily the case. And so one of our challenges is when we think about the continuum of care for behavioral health needs, again, much like diabetes, where there is a very robust continuum of care from primary care to specialty services, we need to build that out for behavioral health too, so we can get people to the right level of care. Right now, regardless of where somebody falls along the continuum of need, whether they have relatively mild depression or anxiety, say, or relatively severe, it all leads to an individual face-to-face visit. And not everybody needs or wants that. And so we really need to build out that continuum with things like digital therapeutics, computerized cognitive behavioral therapies, online behavioral coaching, and a whole host of other options, and a range from just getting medication through your primary care provider all the way to seeing a therapist or a psychiatrist.
Totally. And I mean, I had to hold back my laughter. I mean, how many things must it be true such that we do things and behave in ways as individuals and as a society and as industries because a bearded guy somewhere said it once, that's how that goes. And I think starting to ask those questions is so important. And the thing that keeps coming to my mind, and I would love really to hear what both of you think about this, is that when it comes to harnessing technology at all, but particularly a tool like AI or machine learning to solve this problem, this is a theme we've come back to a couple of times on this podcast because we need to innovate, and it's also so personal and so sensitive, the work that we're doing here. And so how do you balance that need to move fast and innovate quickly with the fact that lives and livelihoods are literally at stake, and there's not necessarily this massive margin for error, nor is there a working model in the healthcare space today that's kind of perfect, right? That we can emulate exactly and scale out. It's kind of like that innovation has to happen in addition to the scaling efforts. And I'm just curious how you both think about managing risk and balancing that with the need to innovate.
From the perspective of a technologist, I think you have to be really careful about understanding the things that technologies like AI can do, right? Which is, if you go back to Roger's sort of point about the continuum of that experience, we think about it as user experience, but let's call it a patient experience because that's what it is in this context, right? There are a lot of things that we can improve without having to replace a licensed therapist in cases where a human being needs to talk to another trained human being, right? But you can improve that entire experience, enabling better connectivity, more effective routing to the right provider with the right level of urgency, right? To track that progress, again, to stay in touch, to provide that frequent sort of touch, human touch, if you will, right? Via better devices. These are things that we can improve. In terms of your point about livelihoods here being at stake and health being at stake, I think many technologies might disagree with me, but I do not believe that technology or AI is in a place where it should replace a human therapist, right? But we can do a lot of things to allow these therapists to see more people more efficiently and to service more people who need their service, if that makes sense.
Totally. Can you talk a little bit more about that? I mean, what else you imagine is possible through technology in between kind of recognizing that there's a potential issue, whether I recognize that or my healthcare provider does in some sort of screening, all the way through to eventually getting connected with, as you say, the right clinician or the right course of care?
Absolutely. When I think about this problem from a technological perspective, right, you can think about it from the perspective of three stakeholders. First, it's the patient, then is the healthcare provider, and then it's the system-wide sort of stakeholder, right? From a patient perspective, we've talked a little bit at length already about how you can improve that experience. You can have recommender systems, routing them to the right doctors. You can have quick, convenient assessment via mobile devices. You can track their progress and communicate with them via mobile devices. That is clear from a patient perspective. From a provider perspective, right? If the goal is to reduce costs, right? We started talking about sort of the market forces and insurance and benefits, maybe not covering some of this thing or covering these services with the right amount of frequency. Well, then the goal should be sort of to reduce cost in overhead and paperwork, right? And increase efficiency. So this is what you can do via technologies like cognitive robotics, process automation, for example, right? Anyone in that office who is processing paperwork, reading documents, entering that information into another system, all of that can be completely automated, right? Allowing providers to actually focus on the things that they're best at, right? Which is treating patients. That's actually where they add the most value. I don't know much about the healthcare space, but I'm guessing these providers are riddled with paperwork, with insurance companies, potentially government entities, patient paperwork. All of that can be automated with simple things like cognitive RPA, robotics process automation, right? And from a system-wide perspective, we can keep lowering those overhead costs via things like using AI to detect insurance fraud in a better way, right? To predict the severity, severity modeling, right? To reduce the cost of infrastructure and data management. And I think by doing all these things, by reducing costs, by helping providers spend more time with patients and less time with process and paperwork, you end up improving the experience for patients, servicing more patients, right? And I think it's generally better for everyone in the chain.
Yeah, I would add that the current payment structure that we have in the U.S. does not support a lot of innovation in this space, particularly with mental health and substance use concerns, and there's a couple different reasons. One is that the market is so fractured. As I said, the vast majority of people are seen in private practice clinics, which is very difficult to organize and coalesce and things. The other thing is that our fee-for-service payment, otherwise known as fee-for-volume payment methodologies, you see a patient get paid for a patient, doesn't support some of the things that we know works that we need to be able to build along this continuum of care, like computerized cognitive behavioral therapy, like behavioral health coaching through a digital text platform, some of these other things. And any cost savings that might be derived by a healthcare system is not, they don't reap the reward of that savings. That savings goes to the payer. So there's a disconnect in how we deal with those things. And I circle back to it's really around market forces. So, and around how we think about behavioral health as a country and mental health parity. For example, what would be the response if 60% of people with a cardiac or orthopedic need were not able to get care? We'd have the industry would have a completely different response. And so we need to think about those in those terms. And as we have these conversations with payer groups and on these national platforms and things, say, I'll accept this with another medical specialty, and using that as the framework. So I think we really need to think about how do we shift the payment methodologies to align the incentives for the healthcare delivery systems and the payers. And rather than moving away from a fee for service and towards more fee for value, are people getting access to care? Are people getting better when they get that care? Are people being screened for these conditions so that we can intervene as early as possible? Because we know that the clinical outcomes are better when we do, and it's way more cost effective. So really at a very foundational level, we need to think differently about behavioral health needs and how we shift the payment methodologies to support building out these continuums of care so we can get people to the right level of care as expediently as possible.
Totally. Yeah. I think one thing I'm getting really excited about is hearing how you're both thinking about expanding this problem in order to solve it, but in different ways, right? It kind of expanding the scope of, I guess, not the problem, but really the possible paths to resolution. I think that's just got to be the first step. It's interesting, though. I mean, both in terms of, Israel, everything you were saying about, I think, challenging, at least even my assumption about AI and playing a role in the kind of direct consumer experience to, get mental health or behavioral health support, which I think is meaningful. But everything else you just said really kind of expands how I think we can think about the role of technology to get more face time between people and providers. And then, Roger, you kind of expanding this problem set to think about like the core of the tension that's driving some of these scarcity issues, and thinking about how we need to solve our payer system in order to kind of even be in a place where we can prioritize effectively when it comes to kind of different health concerns. And I mean, for both of you, how are you approaching these today? I know, Israel, you were speaking more kind of hypothetical, but what are some of those first steps? Like, what are some of the practical steps to start thinking about this? And specifically, what I'm interested in is where are there the opportunities for technology to come in and play a role in advancing this? So maybe we take, Roger, the kind of payer dynamics to start with. So is this the type of problem you see technology playing a major role in solving, or does this go back to finding all the guys with beards that once told us things and calling that into question? Like, how do we approach this?
Yeah, we fundamentally need to change the payment structure for how healthcare systems get reimbursed for behavioral healthcare. And that really takes a partnership between to be frank, the large self-insured employer groups, the state government groups that have large employee bases, the insurance companies, and the healthcare delivery systems to come together and agree upon what that looks like, and to break through those silos. And so it really takes that level of partnership. And a lot of fingers sometimes get pointed at the payers, the insurance companies. If only they reimbursed more, everything would be fine. But that's not. Yes, we need to look at reimbursement rates, but healthcare delivery systems need to come along on this journey as well, and do their part. So I think that's really foundational. And then as we think about, okay, so what are the optimal services that we need to have in place to build that continuum of care, to provide to ensure that the evidence-based care pathway is happening for individuals who are at higher risk for suicide. How do we leverage technology to help fill some of those gaps so that we're not replacing that face-to-face visit, whether it's in person or via video these days, but we're ensuring that people get to the right level of care as expediently as possible, so that those folks who really do need to see a clinician face-to-face or in person one-on-one are able to do that, and we have the capacity to do that.
Awesome. Yeah, I love that. And Israel, back to kind of the notion of expanding kind of the scope of how we look at problems in order to kind of dive in and figure out where to really drive the most impact with technology. Would you say that's part of kind of your typical process of approaching kind of a new relationship, either with a client or in a new industry? Can you just tell us a little bit more about that, about how you figure out where that opportunity to drive some of that augmentation and impact through AI is?
Absolutely. Solving a problem, right, whether you're in a business or in this case, a sort of healthcare scenario, requires you speaking to all relevant stakeholders, understanding where they're coming from, what their needs are, what their problems are. And that's actually something that engineers are actually very, very good at, right? That's essentially what they do. Engineers are problem solvers. I think back to sort of Roger's point, right? We need to get all these stakeholders to sort of talk to each other because, look, I can't speak for all engineers, but I don't know a single engineer. I've been in tech for 20 years. I don't know a single engineer who decided to go through all of those years of school to optimize how many people click on a social media button or see a social media ad, right? They're here to solve problems. And in fact, a lot of my engineers volunteer their nights and weekends building tools to measure the impact of COVID in their communities and doing a number of other things. So engineers want to do the right thing. But I think our society needs to get their values in check, right, in order, because these are the smartest people in the world. They should be solving the most difficult, most meaningful problems for humanity. And we want to be doing that, right? But for example, if we build solutions that, don't get either adopted by healthcare companies or approved by governments, then our hands are essentially tied. And so I think you're absolutely right. We need to get a conversation going that includes all stakeholders, ideally people in tech on that table, understanding the problems from a context where there are no sacred cows, where we can question those assumptions about the bearded men, right, in Vienna. And so, we are, as I think, a community of technologists really eager to add our skill sets and our value in places for society that are much more meaningful than clicking buttons and optimizing ads.
Absolutely. And I think, it takes me back to, I think one of the reasons these discussions can be so valuable is because the things that both of you are talking about, I mean, I can find ways to relate that to my work, as I'm sure hopefully a lot of our listeners are doing. I mean, I hope that the people listening to this discussion are likely already thinking about, whether they're in healthcare or not, how to start thinking more systematically about the role technology can play in solving problems, I think. And we've given really some nice fodder in terms of related to kind of the mental health, the mental health crisis specifically, how we can think about that. One thing, though, that, I like to do as we start to wrap up these conversations is to have a bit more of a practical thought exercise, right? And I know, we all come to this conversation not in any sort of kind of formalized client relationships, just people with perspectives. And so I think that our listeners are really going to want to hear, if we kind of suspend the nature of our relationship for a second and actually think really practically about, how do we get started applying AI to solve some of these problems? And maybe you can both talk a little bit about, or brainstorm together, how do you even prioritize? We've mentioned so many different potential ways in, so many potential issues to solve. And whether our listener is on the tech side or the healthcare side or an entirely different vertical, and they're thinking about, how am I going to start? What is my first step to thinking about bringing this kind of technology, whether it's AI or machine learning or something else, into solving my problems? How do we prioritize? How do we even get started?
Yeah, I think that's a great question. And, and a lot of really smart people are already, working on this. This is probably one of the more crowded spaces in tech right now. I haven't validated this, but last I heard, there's about 100,000 mental health and wellness related apps available through the iStore. And so it's a really crowded space. And but most of it's on the concierge side of the market, where people can download it and they pay a fee and have access to it. So, but I think that one of the ways that is really evolving and has evolved over the last several years is around data. So, healthcare systems are really starting to become data companies in many ways, and using that data to learn how do we help improve not only the health of individuals, but how do we help improve the health of the communities in which we serve and populations in which we serve. And I think that, AI there's certainly a lot of opportunity there, particularly as we think about all the various health inequities that have been around for decades upon decades, but certainly have become those chasms have become even wider in the last year with COVID. The other thing that's starting to happen that's really an interesting area is prospective work. So, currently right now, our efforts around, say, suicide risk screening are based upon asking people questions. There are a couple of vendors out there that are starting to look at, based upon the information that we might have access to and somebody's history, that somebody may be at higher risk of a death by suicide without necessarily saying yes or screening is positive on some of our traditional screens. So how can we do better prospective work to help eliminate those deaths of despair?
And what I'd add is, look, I think Roger is absolutely right. There are a lot of companies, tech companies, focusing on the user experience, the consumer side of this problem. Perhaps a less sexy, but potentially also valuable area would be to help providers sort of better automate their use of that data and their collection of that data, the sharing of that data, right? Sometimes AI is either vilified, they're the hero or the villain. And the truth is AI is nothing but a reflection of the data you're collecting and the use case that you want to resolve with it, right? And so I think maybe centralizing data a little bit more. I know that's very scary to many, especially in this country, not so much in other countries, but centralizing data in a way that allows you to find patterns to help people, right? To help doctors unify their learning, for example, right? And reduce cost overall. I think cost is an issue. It sounds like from this conversation, right, that cost is an issue in terms of how many people get serviced and how frequently. And so I think actually by embracing data and the use of data, as Roger suggests, we can improve that experience for everyone.
Totally. I mean, it's so interesting I think the takeaway I've got is, step one is doing an inventory of the data you've got access to and figuring out if there's opportunities based on that data to create, synergies in your approach to solving that problem where technology can play a role. Would you agree that that's step one? I think with the big asterisk that I'm picking up on from this discussion, which has been a bit of a kind of pleasant surprise, is recognizing that those kind of sexy consumer facing tech experiences shouldn't always be your assumption of your first order of operations, that there's potentially an opportunity to really meaningfully impact the healthcare space, your kind of patient's care experience through applying AI or technology broadly to data sets that you have access to that might not have otherwise come kind of top of mind as the first place to start.
That's right. Look, I think there's a lot of focus on the sexy part, the user experience part, right? A lot of UX designers and technologists have become sort of behavioral experts, right? But actually, if I think about my healthcare experiences, right, I just can't believe that I'm still literally filling out questionnaires with the same information every time I see a doctor. Sometimes it's the same doctor, right? And I have to fill out my history. I have to fill all this stuff out, right? And then, by the way, I need to then get to their office and start writing on a piece of paper all of these things that I've already shared with dozens of other doctors before. We need to start by automating a lot of that stuff, right? And this is where, we might get into a world of scary sort of, Big Brother. If someone's got a centralized sort of history of my medical records, but that's actually what we need to lower costs, right? If we have a way to securely share that data only with the people that actually need to access that data, doctors can see more patients. They can reduce their costs. They don't need as much sort of overhead, right? And people doing that kind of paperwork. You can actually spend your time and your resources seeing more patients. And so I think, let's look at inefficiencies, perhaps more so than the next coolest, user experience application.
Totally, which kind of brings us right back to what you were sharing, Roger, about the inefficiencies and the kind of payer-payee system. And Roger, I'm curious, like, was your process to get there? I mean, I have to assume that this problem is kind of a widely recognized challenge across healthcare and concentrated in behavioral health. But as far as your kind of awareness of this challenge as it particularly relates to mental and behavioral health, like, did it start with an inventory of the data available and finding those shortcomings or opportunities, or was that path different?
Yeah, absolutely. One of the things that we've utilized is to really dive into our data and understand, and we're spread, of course, across 7 states, and really understand the data of those various communities, which differ, and the needs differ, and not only of the larger communities, but also of the patients that we see within those communities, and really to think about where are those gaps, where are those opportunities for us to fill that need, and where are those needs, and particularly as it not only as it comes to behavioral health and substance use concerns, but also with the health equity lens as well. And recently, Providence just put up $50 million over the next several years to specifically address health inequities in healthcare, and one of the ways we're doing that is through data, and using that data to identify the opportunities and then measure the change that we're seeing in those communities as a result of some of those interventions. I think one of the challenges is that as we think about what those interventions might be on the behavioral health side, those things that might be logical interventions aren't always, frequently are not reimbursed in the fee-for-service world. And so while there may be a tool or a care protocol that we know that the research shows is effective, there isn't a way for us to do that in a manner that allows us to continue to do it on a year-over-year basis, unfortunately. And so, that's where, unfortunately, we have to rely sometimes on charitable or foundation dollars, or sometimes it's unfortunately things that we're not able to do because there just isn't a financial sustainable pathway for it. And that's again where I think the larger conversations with care delivery systems and payers and large purchaser groups coming together and aligning over what are those value-based outcomes that we all agree that we want to see, and then how do we align the financial incentives to help us be able to do that in the care delivery in a sustainable way.
Absolutely. I mean, wow. I think if anything, this conversation has expanded the way I've thought about the nature of some of these problems as being, I think pretty kind of simple and straightforward. And there's actually so many layers of complexity, and trying to figure out where to start and how to start and where to go first and which technologies to apply where. I think we've just scratched the surface of some of this, but super fascinating conversation. As a kind of representative of the of people not in the AI or healthcare space directly, I can speak. I hope I can speak for all of us and just say that I'm really glad that minds like yours are thinking about this, because this conversation has really revealed what a massive opportunity we have to make a significant difference in people's lives and livelihood through innovation in healthcare and in technology. So thank you so much, Roger and Israel, for joining us today and for participating in this discussion.
Thank you. My pleasure.